Okay, so this is going to be part 2 of our health history. We left off part 1 with line 40, the right side, which starts with convulsions. So, for convulsions and epilepsy, obviously, if they do mark that, that's going to be a concern. But with the drugs that we are giving in surgery, so the treatment for a seizure, usually the treatment is to just let it happen, let them go through it. You just want to hold them, kind of like if they're on the chair, we want to hold them to where they're not going to fall off the chair. But otherwise, just kind of hold C-spine, turn them on their side. You don't put anything into their mouth. You just kind of let them work through the seizure. If the seizure persists for more than 5 minutes, a seizure that's going to persist longer, we have to stop it, because then that can become an issue with our ABCs, airway, breathing, circulation, mainly airway. So when you give a drug to treat a seizure, it's usually diazepam. So that is a benzo, and in surgery we're already giving a benzo, which is Versed. So the hope would be that for somebody who's having seizures or prone to seizures, that because we're already giving a drug that treats seizures, that we then prevent it from happening during surgery. The next line is stroke. So with stroke, that's going to be a concern, usually just because it's something to look out for. So somebody who's had a stroke previously, the chances of them having another is pretty likely, because a lot of the time it can be from things that are lifestyle related. And if someone's not really making the steps to change that lifestyle, then it can happen again. So stroke, we're going to be concerned with watching their blood pressure, especially checking it when they're coming in. And then the other thing with stroke, so our next line is thyroid trouble, which we're not really concerned with, but below that is diabetes. So it's going to be important that we know our patient's health history, because some of the time a stroke and hypoglycemia can really present almost the same. So you have that slurred speech, unable to really like focus, concentrate, be able to have a conversation with you. If you ask someone to say something, so with stroke, the acronym that they use is FAST. So facial, if you have them smile and like one side goes up but the other doesn't. So hemiparalysis, so one side is paralyzed where the other isn't. So face, arms, you have them put their arms out like this, and then you have them close their eyes, you hold their arms, and then you let them go. If one side falls but the other stays out, then that shows hemiparalysis. The other, face, speech, slurred speech. Also, you can ask them to say something back to you, like you can't teach an old dog new tricks. And if when they repeat it back to you, it's like can't, dog, trick, teach, like it's just a jumbled mess, then that's indicative of a stroke. And then the other is time. So as soon as you recognize that a stroke is occurring, you need to note the time. And that's going to be really important to report that to the emergency team, paramedics, EMTs that are going to come for this patient, because you only have a small window when having a stroke to be able to treat that. And what word am I trying to say? You have a small window of treatment to minimize neurological deficit. So it's really big. Kind of one of the phrases that you can use is like time is money, money is your brain kind of thing. So each, I think it's each second or each minute without blood flow, I want to say it's like 1 million brain cells or something. I'm like 100,000 brain cells. It's a lot. So it's very important that you get that treatment going. So once we would call 911, then the paramedics would call the hospital, and the hospital has a stroke protocol usually, so that they'll have the CT machine completely cleared and ready for this patient to be able to go into it, because the treatment is either going to be like a TPA, which is like a clot buster. If it's a ischemic stroke, meaning they're having a blockage to where blood flow can't reach that brain, or portions of the brain. But the other one is going to be a hemorrhagic stroke. So a hemorrhagic stroke is going to be when those vessels in the brain kind of take on too much pressure and they burst. So with that, you can't give somebody who's having a hemorrhagic stroke TPA, because they're going RTPA. Is it RTPA? I'm getting my words mixed up. But you can't be giving them that if they're bleeding, because you're giving them something that's going to break up clots and thin their blood to kind of get that moving if they're having a clot. But if they're hemorrhaging, then now we're getting into a whole other emergency. So when you're having a stroke and if you're hypoglycemic, some of the time, if you're not familiar with this patient's health history, initially you can kind of be confused on what's going on here. So when somebody is hypoglycemic, they kind of do the same thing in a way. So sometimes they're just not really making sense. They may be slurring their speech. They may have like an inability to control like muscle movement. So they may kind of be tripping or stumbling around. So if you aren't familiar with this, then you may be kind of wondering like what's going on. If you're ever unsure, getting a blood glucose is relatively quick. One of the other things that I teach when I'm teaching this is that you have to think we are in a dental field, obviously, and when someone is having dental pain, they may try to self-medicate. They may self-medicate with opioids. They may self-medicate with alcohol. So if we have a patient who comes in and maybe they are slurring their speech, they are kind of tripping around, you want to be obviously thinking of these more medical, time-sensitive things like stroke or hypoglycemia. But you may also need to look at this patient and think like, are they self-medicating? Is this person under the influence of something else? So keep that in mind as well. With diabetes, you have two types. You have type 1 diabetes and you have type 2 diabetes. So type 1 diabetes is going to be they call it early onset or childhood onset diabetes. Now diabetes is actually being diagnosed really almost all the way up until, my hair's kind of sticking up, it's bothering me. It's really being diagnosed all the way up until age like about 18. So we're seeing diagnosis a lot later in life now. Type 1 diabetes has nothing to do with somebody's lifestyle in terms of their diet, exercise. They're not overweight. This is something that it can be genetic, family history of just diabetes. So the way my brother is type 1, the way his doctors explained it to my mom was that if my mom and her husband have another child together, the chance of them having a child with type 1 diabetes is very likely. And then some of the time it just happens. So with type 1 diabetes, this is the inability of your pancreas to make insulin. So when we talk about insulin, insulin is a facilitator of carrying sugar from our blood into our cells. So if we naturally have glucose in our blood, it's supposed to be there. That's how we test our blood glucose with our finger sticks. We know that glucose is going to be in our blood. However, when you are eating, so let's say I take a cupcake and I eat a cupcake, or I eat something that's very carby, because carbs break down in the body and turn to sugar. So carbs is going to be a thing that you're really going to be paying attention to, and you count carbs. So let's say I take a loaf of bread and I eat a loaf of bread. My blood glucose, so my blood sugar, is going to go up. My body's job is that my pancreas is going to make insulin. Insulin latches on to that sugar that's in our blood and helps carry it into the cells of our body. So that sugar goes into the cells of our body, and we use that sugar in our cells to carry out bodily functions. So like ATP, like that action potential that our body carries. So all those things are going to use that sugar and use that energy in our body. But what happens when you don't have a pancreas that's making or producing insulin, the insulin is no longer there. So your blood sugar or your blood glucose can't just leave your blood and go into the cells. It has to have a facilitator, which is insulin. Without it, it stays in our blood and it builds up. So when you have a pancreas that's functioning, if you overeat sugar or carbs, your pancreas kind of kicks up and makes more insulin, and it helps facilitate that into the cells. So when I test my blood sugar, it's still going to be let's say 130, 140 if I'm, really pushing it. But we're still always in that range, that like safe range, let's say 100 to 130. Now, when you don't have a pancreas that produces insulin, like in type 1 diabetes, that sugar stays there. So now when I test my blood sugar is going to be 300. So that's type 1 diabetes. With type 1 diabetes, this person also really needs to be on top of their sugar, because if you're hypoglycemic, that's dangerous. And more of our concern in the office, and I'll get to that in a moment. And then there's your high sugar. So if your sugar is high, usually consistently you just feel terrible. If it's a little elevated, you can kind of just feel it in your body, the way I've been explained. And my brother specifically, he will like start to get an attitude. So type 2 diabetes, type 2 is lifestyle. So with type 2 diabetes, usually these patients, they have poor lifestyle choices in terms of food choice, exercise, which also leads to a number of things like high blood pressure, and they kind of all go hand in hand. So type 2 diabetes, our concern with them is going to be healing. And really all diabetics, but really a lot of the time type 2. So they are going to have a delay in healing. When we're doing surgery and you're having these open wounds, that's obviously going to be a concern. So diabetes in general, you're thinking delay of healing, monitoring their blood glucose. Type 2 is going to be lifestyle. So this person can change their lifestyle habits, begin to exercise, begin to follow a diet, and then they can go back to being healthy and they no longer have type 2 diabetes. So type 1 diabetes, when we see these patients in our office, a lot of the time they'll have like a little implantable monitor kind of thing that links to their phone. So what I do is I have them change their setting on their phone to where their screen won't lock, and then I have them pull up their monitoring app. Usually most people use things like Dexcom, Freestyle Libre, what's the other one? Can't think of it right now. But it's going to be a real-time monitor because of that device that's implanted, usually in their arm. You can do it, you want to do it somewhere fatty. So your arm, your thigh, sometimes, usually like your little love handle, maybe a place to put it. So with these patients, when they come in, I'll have them change it. I want to see their settings. They are not going to take their insulin dose the morning of, because insulin, like we said, facilitates glucose into the cells. So it lowers our blood glucose. If somebody's not eating, like a type 1 diabetic, if they are not eating, then their glucose is not raising. So if somebody wakes up and they're, at 80 and now they take their insulin and then it drops them, they're going to be hypoglycemic. So they're not going to take their insulin dose that morning. They're going to hold their medications and then they're going to come in for surgery. I'm going to change their settings. I want to see what their numbers are currently at. Usually what we will do is we're going to give them an IV solution that has some sort of dextrose in it. We're going to do that because we rather them be high during surgery than be low. And I'll explain why. So if they're already coming in, let's say they're type 2 diabetes and they consistently sit in the 200s, that patient, we're not going to give an IV solution that has dextrose in it because their sugar is already high. So for that patient, we're going to give something like lactated ringers or just like a 9% sodium chloride, something without dextrose. If they're a type 1 diabetic and they're coming in and their sugar is at 120, we're going to give them an IV solution with dextrose or with sugar, and we're going to bring it up to, let's say, 190, 200, because we would rather this patient go home high, because when they're leaving, we want them to have time to make it home, get settled, and then be able to eat something, adjust their sugars from there. We want to give them that time to get home and get settled after surgery. We don't want to send them out of the office with a blood glucose of 90 and then their blood sugar crash. So consistently, we usually keep it higher, and then that gives them time, since they are fasting, and we want them to be able to have that window to make it home. So when you're explaining glucose, your hypoglycemia is a lot more dangerous than hyperglycemia. So let's say most people will sit around 100 to 120, 130. So if that's where we're sitting and we're feeling good, this is our normal, this is where we should be. You can have a blood glucose that goes all the way up to 200, 250. And then someone might start to report just lately I've been feeling kind of fatigued. I don't really feel very great. That's when they go to their doctor and they start to have these conversations. And then they test their blood glucose and then they realize, hey, you might be type 2 diabetic. But you can also see patients that show up to the urgent care and their blood glucose is in the 500s, and they're still up, walking, talking. Usually these patients, when you see them, they will have, it's like a fruity breath, or some people will also say it's more like an acetone breath. So they are still very much alive. They're up, they're walking, they're talking. 600 is a vastly different number than 130, but they are still alive. For children, this gets a little bit more dangerous, but I've certainly seen seen other reports of adults going into an urgent care and their blood glucose is so high the monitor won't even read it. So they're walking, they're talking, they're alive. Now it's going to be very different from when you're at 130, and if you start to feel hypoglycemic at 60, that window from 60 to 100, or even 0 to 100, that's 100 points. Where when we're starting at 100 and now we're at 600, we've got 500 points there where I'm still up and walking and talking. Where from 60 to 100, below that 60 window, that person may be unconscious. They may be slurring their words. They may not be able to have that brain cognition to even treat themselves. Sometimes your blood glucose drops so quickly that these patients are trying to eat food and kind of bring it up, and it just doesn't happen that way. You know that your blood glucose is dropping, so you're like, oh, let me eat some crackers, let me eat some peanut butter, and before you know it, you're in an entirely different room and people are around you and trying to get an IV started and give you glucose. It's just a window that you can't predict sometimes. So that is going to be our life-threatening glucose level. We don't want to be hypoglycemic. We don't want to be hyperglycemic either, but over the two choices, we're definitely going to pick hyperglycemic. So the next line 44, is low blood sugar. Again, that's going to be a concern because of all the things that we just explained. So kidney trouble, this is going to be something that the doctor really has gone through already during that consultation with them. So it's not something, there's nothing that's really going to happen during surgery that's going to like trigger my brain to be like, oh, kidney issues. That's more of like a longer process. Our kidneys filter our blood, and our kidneys are what produce urine. So if we do have kidney troubles, then this is a patient who during their consultation, we may discuss the fact that, hey, maybe we don't want to give you IV sedation because of an inability for you to be able to excrete this drug. Because if your kidneys are failing to make urine, then all of those medications are going to be in your body and you're not going to be able to urinate them out. So we would have that conversation during the consultation, but this isn't something necessarily that we are going to be looking at as assistance. So high cholesterol, again, nothing that we're really going to be looking at. They may be taking medications for this, but otherwise nothing that is going to pique our interest during surgery. Are you having dialysis? Again, this is something that's going to happen during the consultation. If they are having dialysis, you get dialysis because of your kidneys not functioning. So if they are getting dialysis, they're also going to be marking kidney trouble on their health history form. And this is probably a patient that we would most likely do under local, and if at all. And that would be something that would be discussed during their consultation. Swollen ankles, arthritis, and joint disease. Not particularly something that's going to affect us in surgery, but it is certainly, on that list. Osteoporosis, osteopenia. So this is something that is going to kind of play into part of what we're doing, because if somebody has osteoporosis or osteopenia, that's going to affect their bone. So osteo is bone. Osteoporosis is going to be somebody who usually, if like older women going through menopause, they have less bone density. So if we do have somebody who comes in and has osteoporosis, they may be taking a bone density medication like Fosamax, Boniva, and when we are doing surgery, when we do an extraction, what can happen is that bone density medication can affect their healing and the bone being able to grow back into that location. And then that could lead to something, the next line is going to be osteonecrosis. So essentially, instead of that bone growing back into where it's supposed to be, the bone begins to break down and kind of eat away. So then you can see, I've seen x-rays of it before. I actually had a patient when I was working in Oklahoma. She had cancer, and when we were doing surgery on her, she was having these difficulties with bone, and it led to osteonecrosis. Some of it was a mix of the chemo, others was medications that she was taking. But when we took an x-ray, it was almost like when you saw her jawbone, it looked like spider webs. It was very soft, spongy. There was just really nothing of substance, no bone substance really filling in that mandible. So that would be a concern for us. Same thing if we're going to be doing an implant. We need the implant or the bone to be able to grow into the implant, those screws, or the threading of the implant. So somebody who has osteoporosis or osteopenia and they're taking a bone density medication, then that would be a concern when we're doing implants as well. Stomach ulcer, acid reflux, really not going to be too much of a concern for us, and surgery as assistance. That's something that the doctor can go over, but nothing really that's going to change us and what we're doing. COVID-19, again, don't really care unless you currently have it or you haven't been in good health within 1 to 2 weeks leading up to the surgery. Contagious diseases, again, we don't care. We use standard precautions and we treat everybody the same. Sexually transmitted diseases, again, We don't care. We're treating everybody the same. The only thing I would say that I would care about this is if we have a patient come in and they currently, you can have sexually transmitted diseases in the genital area, but you can also have them in the oral area. So if that's something actively that's going on, it could possibly change how we're going to do treatment because of an active infection. We wouldn't want somebody to have an active infection in their throat or their pharynx and then us be doing extractions. That would probably be something that would really need to consider and wait for them to take their course of antibiotics. Excuse me. Delay in healing, or wait, I'm sorry, I skipped one. Problems with the immune system. This is going to, someone may mark this if they're diabetic because of that delay in healing, which is line 57, delay in healing. They'll usually mark that if they're diabetic. Something with the immune system we would be concerned about in terms of infection, or maybe if somebody is in the midst of a cancer, like chemotherapy treatment, this person's not going to have an immune system, so they're not going to be able to fight off an infection. So something that can be a regular infection for me may be life-threatening for someone else. So tumor or growth, they will most likely mark this if they're here for a biopsy, or it may be something else that is completely separate of this treatment, and then we would just want to know that what they're doing for that treatment, because if somebody is in the midst of chemotherapy or radiation, again, that may change how or when we treat this patient. Next line, cancer, radiation, chemotherapy, again, just said that. Chronic fatigue and night sweats. This could be a multitude of things. The first thing I think of when I'm reading this is, to be honest, tuberculosis. But again, we would just need, some people just mark that because they sometimes drinking alcohol. If you consistently drink alcohol, that can lead to sweating at night. So really that's kind of a very vague question, but it is on there. Are you on a diet? Again, not really bothered by that question. There's nothing that would stand out for me. Is there a history or treatment of alcohol use disorder? So this may be a question because if you have a history of alcohol use disorder, then that could be affecting your liver. And again, we said our liver is what breaks down the drugs that we're going to be using. And not only that, but we said that the night before, if someone's drinking, that will affect how their anesthesia is going to go for us the day of surgery. So that's something we're going to want to check on. Is there a history or treatment for marijuana or substance use disorder? Marijuana does affect anesthesia, especially that mild to moderate sedation. So we've had it before. If somebody is chronically smoking marijuana, we've had it. We used to say you need to stop 2 days prior to the surgery, and that really is the most minimal time that we can recommend. And honestly, even when we do that, it does not help us. So realistically, we would prefer somebody not to smoke 1 week leading up to the surgery. And for somebody who chronically smokes all day long, every day, or even just every day, really, sometimes even that week long is truthfully not even long enough. We are just barely able to kind of get through the surgery. And you never know though until you're in that situation. So then you have to weigh the risk versus reward of like, okay, is this just a patient who we're going to have to take frequent breaks during surgery and kind of reorient them and be like, hey, let's take a break. You're okay. You're doing well. We just have, to do this and that. Because these patients, the way I explain IV sedation to moderate to deep sedation is that we want these patients to be safe and breathing on their own, but they're not intubated, so they don't have a tube down their throat. They don't have a paralytic. Some of these patients may have their eyes open. They may be talking to us. So the way I explain it is like it's being blackout drunk. So you may have your friend who's blackout drunk. They're running around the bar. They're talking to people. They're having conversations. You also can't reason with them. So, if they're trying to get into a fight with somebody or they're trying to do something crazy, you may be like, hey, don't do that. That's illegal. That's not a good idea. And they don't listen because that's just not how our brain works. When we've put so many substances in our body, we don't have a rational thought. So the way I explain this IV sedation is that it's like being blackout drunk. So you see this person, they are sedated, they aren't going to remember the procedure, which is kind of the goal of sedation. It's usually we're just using it for anxiety and wanting to make this an easier experience on them, which some of the time may make it a harder experience on us. But these patients are arousable. You can tap them on the shoulder. Hey, deep breath through your nose. Hey, open your mouth for me. And they're going to respond and they're going to listen. And sometimes patients are very sedated. Their eyes are closed, they're not moving, they're not talking. Really, to even get them to respond to you is a really difficult task. But it's just an array of patients and how somebody is going to respond. So you have those patients who are wonderful, completely sedated, won't open their eyes the whole time. Even when surgery's over, they're still sleeping peacefully. And you really have to give them more time to even wake up. And then you have other ones who they may talk a little bit more during surgery. They may kind of move around a little bit. They are like, how was your weekend? And you're like, oh, good, just keep your mouth open, no talking, breathe through your nose kind of thing. And they just want to talk. Or you have other ones who, when you do substances like marijuana or alcohol, it really does affect the anesthesia. So it almost has the opposite effect to where instead of being very sedated and sleepy, they're very arousable. Next one, contact lenses. So we need our patients to remove any contact lenses because we are going to usually give a drug that is an anticholinergic. So anticholinergics dry out mucous membranes. This is going to be your mouth, which is why we're giving it, because we want to have a clean, dry area. So that means less saliva that can go down your throat. So it helps us for that aspect. But in return, it also will dry out their eyes. So we don't want you to have contact lenses in and have extremely dry eyes. The next one, eye disease and glaucoma. Again, nothing particular for us in that moment is going to be a red flag. That's something, if there was something of concern, it would be discussed during their consultation. Mental health problems, anxiety, and depression. This is one, even when I am assessing the patient, when I'm connecting them, I am looking at their arms to see if there's any cut marks. I'm looking at their stomach, their thighs. We're looking for cut marks because that can be a sign of anxiety and depression or mental illness. And if they have maybe PTSD, the reason we're doing this is because we're giving a drug called ketamine. And ketamine can produce bad dreams. So we want to make sure that if we're giving this drug, we're going to give it to a patient who isn't going to have a adverse reaction to that. Removable dental appliance. I don't particularly care. The only thing you're usually going to run into with this is that they're going to ask you when they can put it back in. I just say usually wait 3 to 4 days and then you can put it back in. And your teeth aren't going to shift that much over the course of 2-3 days. And if they do, you're just going to put your retainer back in. It's going to push everything back to where it's supposed to be. So just wear it whenever it's comfortable. Pain or clicking in the jaws when eating. So commonly, we as an office don't treat TMJ, but I did treat TMJ when I worked in Oklahoma. And I will say that 9 times out of 10, when somebody came to our office and they still had wisdom teeth and they had jaw pain, when we took their wisdom teeth out and they did a follow-up appointment and came back, they no longer had jaw pain. So a lot of the time that's going to be resolved by taking those wisdom teeth out. And then the other thing that I just like to say is that joints click and pop. Our knees click and pop, our wrists click and pop, my fingers click and pop. So that's just something that joints do. So clicking and popping is fine as long as it doesn't come with pain. If it's coming with pain, then that's a different problem. And we hope that by removing wisdom teeth and that's something that resolves itself. But if it doesn't, we as an office don't treat TMJ, so they will need to see someone else. Is there a possibility of pregnancy? If somebody is pregnant, then we usually don't want to do anything in that first trimester of pregnancy because you are going to be very cautious with pain medication during that time. And there's a lot of things that are forming in the first trimester that we really don't want to mess with. One of those being the cleft palate here. So things like ibuprofen can be one that if you're taking ibuprofen, it can prohibit the fusion of the cleft here. So that's when you'll see that cleft palate. So we usually try to stay away from doing anything during the first trimester. Are you nursing? So if they're nursing or breastfeeding, then we don't want them doing that if they're going to be taking opioid prescriptions. Or if they're having IV sedation, we don't want you to go home and breastfeed today. Taking birth control pills. Most birth control pills are okay with the antibiotics that we're giving, but there's some that are not, so you just need to possibly look into that. Taking any type of medications, drugs or pills, obviously that's something we want to know about. We do a lot of hiring with assistants who have no experience, and we train them to get their certifications. So I say that by keeping in mind the fact that we are aware that you do not have a familiarity with drugs. With that being said, you need to. So make it a point that when you are starting to learn, pick one drug per day. Write that drug down. If you see a drug in somebody's health history, write that drug down, look up what it does, see in their health history what they have marked that correlates to that. So if I see somebody is taking, we use labetalol, so I'll just say labetalol, even though they're not going to be prescribed labetalol. But let's say I see labetalol in somebody's health history, then I'm going to scroll up and I see high blood pressure. I can know, okay, that is how this correlates. This is what they're taking this for. Or if somebody has some sort of, like, okay, let's say the one that's on here right now, because I'm looking at, my brother's health history, which I have permission to speak about. So this isn't any disclosure of information that's illegal. Let's put that out there right now. But his health history is Humalog, which is a diabetic medication. And then guess what? When I scroll up, it's marked diabetes. So when you're starting out and you're new, you don't know what Humalog is. You don't know like these insulin drugs. So make it a point every day, at least pick one. I would say even better, maybe pick 3. Google those, write them down, write the name of the drug, and then write down what it does. Kind of do that repeat process, write it down 10 times, and then do that every day. Sorry, my dog's trying to get attention. Write that down every day. And then eventually when you see these drugs, you're just going to be like, oh, I know exactly what that drug does. And then you're going to see in their health history where that correlates. Next one, let's see. Blood thinners, Coumadin, Plavix, aspirin, vitamin E, ginkgo, Xarelto, Eliquis, fish oil. These are all going to be blood thinners. And again, we know our risk with blood thinners is going to be bleeding during surgery and after surgery. So usually when somebody's taking a blood thinner, we, if they're showing up as an emergency, 9 times out of 10, we're not going to do that surgery today because we need them to hold that blood thinner, which means we need to reach out to their prescribing physician of that medication and ask them for a clearance. That clearance is going to say something along the lines of, hey, this is our mutual patient. We are going to perform this surgery procedure. We would like guidelines on their blood thinner Plavix. And then we usually get something back from that physician that says, hold this medication 3 days prior to surgery and resume next day. So we have to follow that. If there's any deviation of their medications, directions, you can see my baby back there. So if there's any variation in the direction of the prescription, we don't have the permission to change what that doctor has prescribed. We can't tell that patient, yeah, just hold it for 3 days and then come in. We have to get written approval from that physician. Are you taking any diet pills? This didn't used to be a concern. Nowadays, I'm going to say that is a different thing entirely. So now there is something that's become very prevalent called Ozempic. Ozempic is a diabetic medication that people are using for weight loss. I don't know about any other drug names. I specifically am very familiar with Ozempic. So Ozempic is a diabetic medication, but this medication delays gastric emptying. So what it does is it makes somebody feel full longer. So it stops them from over consuming food, or even not even over consuming food, but just really consuming food in general, which leads to weight loss. However, we know that typically digestion takes a few hours, and then by the time somebody's come into us and they are NPO, we know that their stomach is going to be empty, which then when we sedate them, when you're sedated, your muscles relax, and your stomach muscle is going to be one of those. And if somebody has something in their stomach and we give these medications, then what can happen is those muscles relax, triggers them to vomit, and then they can aspirate that back into their lungs, which again would be a medical emergency, airway, breathing, circulation. So something like Ozempic, where it's delaying stomach emptying, the time that we're telling them to be NPO may not be sufficient. So that is going to be one that is very important. It didn't used to be something that was really focused on. It used to be that when I went through this health history, I was like, oh, diet pills, don't care. But now we really do need to focus on that. So also things are very much changing. So, I'm making this video right now. It's the beginning of 2024. If you guys are watching this video 2 years from now, some of these things that I've gone through and said, well, we don't care about that. That could have changed as well, but this is where things are standing right now. Natural product, herbal supplement, homeopathic remedy. Again, there are going to be some things like some herbs that can lead to bleeding, or can counteract with other medications. So it is important that we know some of these herbal supplements. Have you ever taken any bone density medication? So we did go over that with that osteoporosis, osteopenia, osteonecrosis, part of that health history form. So if they mark that, then again, we want to be paying attention to that. Tranquilizers, sleeping pills, antidepressants, and or narcotics on a regular basis. Again, that's really going to change how we treat things, because if we're giving these medications and you already are possibly taking the max of a tranquilizer, we could then overdose this patient. So we really need to be aware of those. And then if you're under the care of a physician for pain management or recovery of drug addiction, again, we need to know if somebody's under the care of a physician for pain management, we legally can't prescribe them pain medication. They have to get their pain medication prescriptions from that pain management doctor. And then just also knowing that somebody is in recovery or is struggling with an addiction really helps us, because there are options that we can give to these patients to make them feel more comfortable, to make us feel more comfortable, and to just overall have a better experience for this patient. So if somebody says that, they struggle with addiction, then we can have these conversations where we say, we can do IV sedation and not give you IV narcotics. Or we have a drug called Exparel, which is an extended numbing medication, and we can give them that and they can rely on that extended numbing relief rather than using prescription pain medications. Instead of prescribing somebody a Percocet, we could prescribe them possibly a Tylenol 3 with codeine if that's something that would work for them. Some people that may even be too close of a risk. So instead, we may discuss using Tylenol. You can use Tylenol 1,000 milligrams combined with 800 milligrams of ibuprofen. You can take those together. You would take that every 6 to 8 hours. And there's actually a study that shows that 1,000 milligrams of Tylenol, and for whatever reason, specifically Advil liquid gels, the liquid gels specifically, taking 800 milligrams of that. So combining those two, and that had proved a stronger pain control than a prescription opioid. So really just going through all our options and making sure that our patient is comfortable and that we're comfortable and that we feel like we're doing the best that we can for them. Are you allergic to or had any reactions? So local anesthesia, if they've had any allergic reaction to that, then that's something we're going to be aware of. We won't give a patient who usually has like some sort of cardiac condition, we're not going to give them lidocaine with epinephrine because it has that epinephrine in there. Some people are also very sensitive to epinephrine, so that may be a concern. Usually sometimes people will mark that, and really what they're referring to is they say, oh, it just doesn't work for me. I had Novocaine and it didn't work. And I say, well, we don't really, use Novocaine anymore. Usually what we use now is lidocaine. And we just kind of, go with the flow. Usually we'll give the lidocaine and then we test it. And I tell them, we're going to test it before we do anything. We're going to, touch around the tooth and make sure you don't feel anything. If you do, we'll adjust what we give you. And they're usually okay with that. Penicillin, if you're allergic to penicillin, then most likely you're allergic to amoxicillin. Not only that, but then cefazolins. If you're allergic to cillins, you're usually allergic to cephs. So a patient who comes in for IV sedation, if they have on here that they're allergic to penicillin or they're allergic to amoxicillin, then if we want to give them an IV antibiotic during surgery, we're going to probably not give them cefazolin, which we call also Ancef, because cillins and cephs kind of really go together. So instead, we would probably give something else like doxycycline or clindamycin. And we also want to be aware of that because if we're prescribing them something like an antibiotic for them taking at home, then we want to give them something that's not going to cause a reaction. Sulfa drugs, there is propofol that is preserved with sulfa. That is not the kind of propofol that we currently order. We have come close to almost having to order it in the past due to back orders on drugs. Also, I'm sure you guys can probably hear my dog snoring right now, so I'm so sorry. You're very sleepy and snoring. Sorry, guys. Just be aware of that. There is propofol that can be preserved with sulfa. Let's see, sodium, pentothal, Valium, other tranquilizers. They're allergic to benzos. Again, we give benzos during IV sedation, so we want to be aware of that. If they're allergic to aspirin or they can't take like aspirin and NSAIDs, we want to take the ibuprofen out of their post-op bag. Codeine, other narcotics, latex. We are a latex-free office, so that's usually not of concern. If somebody has a food allergy to, I believe it's bananas and kiwis, there's also a strong chance that they will be allergic to latex. So, something to keep in mind, but again, we're a latex-free office. If they're allergic to soy, propofol contains soy. Eggs and egg yolk is also another one that you want to be careful with propofol. There is studies that show that the digestion and the way the body breaks down an injectable IV drug is different from how it would be broken down for food. So there are some studies that say it's safe, but it also just depends on how severe their allergy is. I've known, I worked with a doctor who, if he would say, you know, they'd say, oh, I'm allergic to eggs. And he's like, okay, you know, how allergic are we talking? Like, could you sit down and eat a plate of eggs? And they're like, oh, no. And he's like, okay, can you eat things with eggs in them? Like, can you eat a cake? And it really just depends on how severe their allergy is. But we usually kind of just patient dependent on how severe things are and how things are going that day. And then any other known allergies, foods can kind of cross allergy lines with other things. Like I said, like latex and bananas. I've seen like parents write like any other drugs, and it's like Pampers. I'm like, they're 18 now, so I think we're beyond that window of being concerned for a Pampers allergy, but thanks for letting us know. I would almost rather have way more information than we ever needed than somebody not be thorough with us, because we have had that before where the patient's parents weren't particularly honest about their health history, and then that just led to emergency situations in the office that were 100% preventable. So that wraps up our health history. The bottom of it is just about family history, which again, not really too much of a concern. Things like, is this visit related to an accident? That's really not so much a concern for me. Like maybe the insurance would be going through workers' comp or something, or like somebody's insurance policy. I don't know. Again, that's just not something we're paying attention to in the back. And then it's just signatures beyond that. So that wraps up part 2, and that is it for health history.